Yeah, first of all, I'd like to thank the organizers and especially my friend Zhang Daoyu for this next invitation here to Germany, to China. It's always a pleasure to come here in this exciting country. My topic is interventional treatment with drug-eluting balloons. And well, it started quite a few years ago, and more than 10 years ago, with the first controlled randomized studies comparing drug-eluting balloons versus normal plain old balloon angioplasty in, at that time, bare metal stent in-stent restenosis. And it showed that dilating the restenosis, which was at that time about 25 to 30% of the in bare metal stents, treating this restenosis with a balloon coated with a drug did very much better than just with a normal balloon. As you can see here, I don't mention it, the minimal late lumen loss in the only POBA group was well, quite substantial compared with the coated balloon, which has a much better minimal lumen diameter. So at that time, the consequence and result was, well, if you have an in-stent restenosis, try to treat it with a drug-eluting balloon. This also translates in clinical meaningful endpoints. You have a better event-free survival if you treat the patient with a drug-eluting balloon in patients with a bare metal stent in-stent restenosis than just plain old balloon angioplasty. This after 1 year. Whoops. Does it recover after a certain time? No. Even after 2 years, the patients which have been treated with a coated balloon still fare much better than patients treated with an uncoated balloon. So the event-free survival was much better, and this was statistically significant that drug-eluting balloon angioplasty is better than uncoated balloon angioplasty. But at that time, drug-eluting stents came on the market. So the question was, is a drug-eluting balloon better than just putting a new developed drug-eluting stent into the first bare metal stent? And this PEPCAT-2 study compared these two treatment regimens, and as you can see here, the minimal lumen diameter for the drug-coated balloon is, for the drug-coated balloon this here, that column is slightly better than the minimal lumen diameter for the drug-coated stent, drug-eluting stent. No, there it is. Yeah, which has a slightly worse minimal lumen diameter than the balloon. So this was not statistically significant. So as you can see, the drug-eluting balloon for treatment of bare metal stent in-stent restenosis is about equal than putting another stent in it. Anyway, if you treat a bare metal stent in-stent restenosis with another stent, you end with probably several layers of metal in the coronaries, and I don't know if you really want that. Does this translate also in clinical meaningful endpoints? Here is the 1 year results for event-free survival, and you have a trend to a better outcome with a drug-eluting balloon in BMS in-stent restenosis than with the drug-eluting stent, but this just failed to reach statistical significance. Well, drug-eluting stents diminish significantly the rate of in-stenosis, but however, there's still a 10%, 8%, whatever, rate of in-stent restenosis after drug-eluting stent. How to treat this? Well, the first trial was angioplasty or drug-eluting balloon, and as you can see here, MACE-free survival after treating DES in-stent restenosis with a drug-eluting balloon is much better than just a normal plain balloon. But could you probably treat a DES in-stent restenosis with another drug-eluting stent? And this was tested in the ESA-DESIRE 3 study, and as you can see here, diameter stenosis at follow-up angiography showed that treating a DES in-stent restenosis with a balloon angioplasty, the blue line, was much worse than treating a DES in-stent restenosis with either another drug-eluting stent or a drug-eluting balloon. However, if you use a drug-eluting balloon, you have less metal, less material left in the patient. How should we treat in-stent restenosis with a drug-eluting balloon? This is a not randomized registry looking if the pre-dilatation, if the preparation of the stenosis has any consequences on the definite result. And they showed in their own registry and showed that if you have a bad lesion preparation, meaning a more than 30% restenosis, for example, after the first balloon angioplasty before the drug-eluting balloon, then the outcome is worse than if you have a good pre-dilatation with less than 30% in-stent restenosis, no dissection at all. So it's crucial. If you use a drug-eluting balloon, you have to pre-dilate with an adequately sized balloon, probably high-pressure balloon, to have a good lesion preparation before you put your drug-eluting balloon in. And this is a case report on a new developed bioresorbable vascular scaffold patient. Is it probably also useful to use a drug-eluting balloon in cases where the scaffold failed? Well, this was in that upper left picture was a CTO treated with a scaffold. The result of after scaffold was fine, but after 6 months, you still have another reocclusion. But the reocclusion was treated with a PDCA, with a balloon angioplasty, and afterwards with a drug-eluting balloon. And this was the result another 6 months later. So treating a bioresorbable vascular scaffold failure, either restenosis or reocclusion, with a drug-eluting balloon is maybe a good option. This is not a large study, but at least you can think of. However, the scaffold implantation rate has decreased substantially in the last month. This is a series of 9 patients where the restenosis rate was, acceptable. Well, this is in-stent restenosis. What about drug-eluting balloon in de novo coronary artery disease? And several studies, and I'll show you a meta-analysis of these studies showing that for de novo coronary lesions, the best treatment is a drug-eluting stent. The worst treatment is a bare metal stent. And bare metal stent with a drug-eluting balloon is an intermediate result. So in native coronary arteries, if you have the availability of a drug-eluting stent and you have the possibility to implant it, then this is still the best strategy. Bare metal stent and drug-eluting balloon is second best in these cases. Could this be improved? Probably. There is a registry from Jena, and looking if you, for example, pre-dilatation, good pre-dilatation and drug-eluting balloon angioplasty controlled by fractional flow reserve could probably an idea where you can avoid some some stenting if you want to avoid that. And at least the first results, it is feasible and safe using that. This is not a randomized study. This is just a registry, and the late lumen loss seems to be very good in these patients. So probably in the future, treating coronary artery disease with bare metal stents controlled with fractional flow reserve could be an alternative. Next field is, what about small vessels in native coronary artery disease? The question or the problem is always, if you have a restenosis or a late lumen loss of, let's say, about 0.3, 0.4 millimeters in a 4.0 vessel, well, this is not really a restenosis. If you have that, late lumen loss in a small vessel, let's say 2 millimeters, then you have a significant restenosis. Could it be better to avoid stenting in these patients and use just a drug-eluting balloon? This was investigated in the so-called bellow study, comparing drug-eluting balloon and DES in a randomized fashion in small vessels below 2.5 millimeters. And you see here the late lumen loss with the drug-eluting stent in this blue line was even larger, even higher than with the drug-eluting balloon. However, you have to admit these were first-generation drug-eluting stents, so probably these results cannot be applied to second or third generation drug-eluting stents where the late lumen loss is less than with the paclitaxel using. Anyway, if you in small vessels, if you use drug-eluting balloon, you have a good result, and you have achieved a good result. This good result will last for several years. So the maze-free survival after drug-coated balloon in small vessels, there is no arrow. This is the red line is very good. You have very few major adverse events. Could drug-eluting balloon be a solution in patients where you have to treat a bifurcation? Well, bifurcation is always tricky. One stent strategy, two stent strategy, important side branch, not so important side branch. Probably it's good to use a drug-eluting balloon and not putting another stent in it. So this strategy was investigated in a PEPCAT 5 registry, not a randomized study. And well, they show that using a bare metal stent and a drug-eluting balloon in the main vessel and treating the side branch only with a drug-eluting balloon results in what they call DES-like results. Well, probably yes. And one case report I'd like to show you is a biodegradable strategy in one of the most difficult cases for interventional cardiology. This is a CDO and a bifurcation. And you have here a CTO of a rather large circumflex at the bifurcation with a marginal branch. And it was treated with a recanalization of the CTO. The main branch was treated with a scaffold, and the side branch was treated with a drug-eluting balloon. So they have this bifurcation and this circumflex without any metal. And this is the 6 months angiography, control angiography, showing a good result without any metal. So this is a case report, but probably in the future the leave nothing behind strategy could be good. Lesion preparation, once more, before using a drug-eluting balloon, and a new balloon has come to the market, so-called scoring balloon, which is a balloon with files on the surface, a little bit like the cutting balloon, which less traumatizes the artery during inflation. There's a more controlled inflation, and this ISA Desire 4 compares pre-dilatation with a normal balloon and pre-dilatation with this scoring balloon, which you have to inflate very slowly, about a time more than a minute, leave it in place for another minute to get the tissue really cut the tissue and not, burst it. And if you use this method, it seems to be that in this study statistically significant. You have better results if you really smoothly prepare the lesion before using a drug-eluting balloon. And the latest development is a scoring balloon coated with a drug. And this is the first randomization using the drug-coated balloon, drug-coated scoring balloon, or the drug-eluting non-scoring balloon, and the paclitaxel-coated scoring balloon fares better after 9 months than the non-drug-coated scoring balloon. However, small numbers of patients, this has to be determined in the future. And you can use also drug-eluting balloon in non-coronary cases. This is a case of a patient with a Williams syndrome. I have to admit I did not really understand what it is, but it is a syndrome with pulmonary artery stenosis, multifocal, and treatment is either surgical or with a balloon. And after you have treated it with a balloon, it recovers, it comes back, and another restenosis, and you can treat even pulmonary arteries with a drug-eluting balloon. At least for some time, you can relieve the patient with the symptoms. So, in conclusion, I think a good indication, a good treatment with a drug-eluting balloon is if you have in-stent restenosis. Probably it's a good idea to use drug-eluting balloons in small vessels. Probably it's good to use drug-eluting balloons in bifurcations, and what the future will bring, what the future will show, if the drug-eluting scoring balloon is an option for the future, and if you have other indications outside the heart, for example in peripheral artery disease or in the pulmonary arteries, has to be determined. And I think we put the laser pointer away now. Thank you very much.